Hypertension, a condition commonly known as high blood pressure, is a public health problem that affects both developed and developing nations. According to the American Heart Association, hypertension is the most important risk factor for heart disease and stroke in the United States. Despite substantial improvements in public awareness, clinical diagnosis, and treatment, the number of patients diagnosed with hypertension that successfully respond to medications is suboptimal. Hypertension has been well recognized to provide additional risks to patients with diabetes, atherosclerosis, and atherothrombotic cardiovascular disease, leading to an increased likelihood of myocardial infarction, stroke, peripheral vascular disease, renal failure, and heart failure. Hypertension is postulated to result from numerous pathophysiological mechanisms including increased peripheral resistance, increased sympathetic nervous system activity, overproduction of sodium-retaining factors and vasoconstrictors, increased sodium reabsorption by the kidneys, deficiencies of vasodilators such as nitric oxide and prostacyclin, or from an imbalance in the regulation of glomerular pressure, all of which are difficult to isolate as the cause of hypertension. The Hypertension RAS PhysioLab was initially developed by Antelos to investigate the effects of antihypertensive therapies on blood pressure regulation and renal function in diverse patient phenotypes. Renin-angiotensin system or RAS-based therapies have effects on slowing the rate of renal disease progression that are not observed in non-RAS-based therapies in patients who have decreased renal function. Multiple studies have shown that patients on RAS-based therapies have a slower rate of decline in glomerular filtration rate or GFR and decreased albuminuria compared to non-RAS-based therapies. To investigate the effects of antihypertensive therapies on clinical level outputs such as mean arterial pressure, GFR, and albuminuria, the Antelos Hypertension RAS PhysioLab incorporates the underlying biology of the systemic and renal renin-angiotensin-aldosterone pathways, a model of the blood pressure regulation based on the Guyton-Coleman model, a model of renal filtration based on work by Dean and Lazzara, and a model of the effects of blood pressure, angiotensin II, and glucose effects on renal disease progression. The goal of this model was to investigate the relative effects of therapies such as ACE inhibitors, angiotensin receptor blockers, direct renin inhibitors, or aldosterone antagonists on the secondary endpoints of renal function and disease progression in a range of hypertensive patients with comorbidities such as diabetes. Calibration of the model parameters was done using data from a range of small and medium-sized studies. Some of the studies used to calibrate the initial response of hypertensive and diabetic hypertensive patients to RAS-based therapies are listed in the top table, showing the available data for changes in GFR, albuminuria, blood pressure, and RAS biomarkers. Long-term disease progression data was taken from studies in the bottom table. Specific emphasis was given to studies that track the long-term changes in renal function of diabetic patients due to their increased likelihood for developing renal disease. Calibration data for diabetics was separated into three separate classes: diabetics with normoalbuminuria, diabetics with microalbuminuria, and diabetics with macroalbuminuria. Model validation was conducted by simulating the changes in blood pressure, GFR, and albuminuria in two large trials of RAS-based therapies, RENAL and AVOID. These studies looked at the changes in these clinical endpoints of diabetic patients with different stages of nephropathy in response to losartan, an angiotensin receptor blocker, and aliskiren, a direct renin inhibitor. When compared with the published results in the RENAL and AVOID studies, the model predictions of the average change in blood pressure, GFR, and albuminuria were similar to the published data. The results highlighted the relative roles of hypertension and diabetes on renal disease progression and suggested additional strategies for optimal combination of therapies to slow the progression towards renal failure.